We're going to talk about care in pregnancy of mothers and babies with congenital heart disease throughout this whole session. And as I say, we're going to concentrate on the mothers in the first instance. So where are we? We all hopefully know where we are this morning. It's still only 9 o'clock, but hopefully everybody knows where they are. So Yorkshire and the Humber, we have a population of about 5.6 million, and between 0.5 and 1% of the population have congenital heart disease. So if we bear in mind that we've got 60 to 65,000 deliveries per year in our region, you can see that that's a significant number of women with heart disease that are delivering. So somewhere around 650 women a year delivering across the region with congenital heart disease, and then we have the patients with acquired heart disease on top. So what do we offer in the network? Well, we offer cradle to grave care, and we're obviously not interested in all of these patients today, but certain groups. So the pregnant woman here in the middle of the screen, a very, very important part of people's lives, a very major event for many of our women. So some of them who've got complex disease as children were told, or families were told, that they would never be able to have children of their own, and lots of them are bucking that trend and doing it anyway. We're also looking today at the babies, another massively important part of life, both for the babies themselves and for their families. So this is what the network looks like geographically, and you can see that it's quite complex, and it's geographically quite a broad area. So we go down as far as Chesterfield in the south, up as far north, past Harrogate, up towards the North York Moors National Park, and then people that are further north of this line tend to travel northwards to Newcastle generally. There's quite a long distance from Scarborough into Leeds, from Grimsby into Leeds, and then people over to the west tend to migrate into the Manchester and Liverpool networks. So we have one paediatric surgical cardiac centre, one adult congenital cardiac specialist centre. There's a super regional pulmonary hypertension centre within our network area, for which I'm eternally grateful, with 3 adult cardiac surgical centres, so Leeds, Sheffield and Hull. And then we offer maternity services at 18 hospitals. So the interrelationships between all of those care delivery centres are quite complex. All of the complex congenital patients, so the mums that have congenital heart disease, or patients that need same site delivery, and for some patients there are advantages to that, which we'll touch upon later on, will end up being delivered in Leeds. Most of the severe pulmonary hypertension patients will be delivered in Sheffield. And this is really how things are shared out across the region. So in Leeds, we'll see patients with complex congenital heart disease, patients requiring same-site delivery, and the moderate and severe acquired cardiac from West Yorkshire, the Leeds-based mild and moderate complex congenital defects. Hull will see the East Yorkshire section, and Sheffield, the South Yorkshire section, along with pulmonary hypertension in Sheffield. And local units are generally very well set up to manage their mild congenital or acquired cardiac patients on site. So why is this really important? So if anybody is looking for some bedtime reading that will keep them awake, unfortunately, at night, it's this. So the Embrace report. This is the most recent iteration, so December 2020. And this is maternal inquiry over the 3 years, 2016 to 2018. And these are published annually. And this shows, so the reason I say it's not good bedtime reading, because it keeps you awake, is it's full of horror stories, really, of patients where things have not necessarily gone according to plan, and there's been some tragic outcomes. So after a sustained fall over time, overall maternal mortality rates in the UK are now remaining static. So we did see this overall fall. This is all deaths, and then it's gone static, and if anything, starting to tick up a little bit at the end. And unfortunately, heart disease remains the leading cause of maternal death in the UK. So that's something that obviously concerns us greatly, is that continues to be the case. So you can see that cardiac disease outweighs VTE, neuropsychiatric sepsis, obstetric hemorrhage, all these other issues are pretty much dwarfed by cardiac disease. And unfortunately, cardiac deaths are increasing. So this slide set is taken from the 2016 report, which concentrated on cardiac. I've just extrapolated here the most recent mortality rate, so 2016 to 2018. And you can see there's still a slight continued increase in cardiac deaths, despite all the attention that it's given and education that goes on. And really, what are the causes of this? So potentially increasing obesity, older mothers, maybe it's just related to better data, so better cardiac data, better post-mortem data, and potentially also increased numbers of mothers arriving from overseas, where there may be an increased rate of things like rheumatic fever, rheumatic cardiac disease, which is not recognised prior to their pregnancies. And then again, this is taken from the 2016 report. So 8.5 women per 100,000 died during pregnancy, and 2 of these were from cardiac disease. So if we again look at our own region of 5.6 million population, we're looking at 6 to 6.5 maternal deaths a year related to cardiac. And that's you look at those figures and think that's expected. Well, that's horrific to me. I'd be terribly disappointed if we had that number of deaths per year related to cardiac disease. So these are the key messages from the cardiac report, so 2016. And these are really important. So heart disease can happen. It's still really rare, isn't it? So we kind of, assume that those common symptoms are related to common pathologies. So persistent breathlessness, even heavily pregnant women should not be persistently breathless when lying flat. And that's a sign of a problem. Women with heart disease are high risk and they need specialist care. And we should all be aware that severe chest pain spreading to the left arm or the back may be cardiac. And I kind of worry a little bit about this infographic because it doesn't necessarily need to be severe chest pain spreading to the left arm or the back. It can be a bit more non-specific than this. This is very classical description of cardiac sounding or aortic sounding chest pain. But in women, we know that those symptoms are often a little bit vaguer. And I think we should be just a bit aware that this may not always be the case. And we shouldn't be saying, oh, the pain's not severe, it's not going to the left arm or the back, it's therefore not cardiac. I think we just need to be quite clear on that. Why do patients die? 2 real reasons. So because of the very specific effects and very marked effects of pregnancy on the cardiovascular system, which we'll look at, and sometimes, unfortunately, because of poor care or lapses in their care, is a contributory factor into patients' deaths. So what happens to the cardiovascular system during pregnancy? They undergo massive changes. It's quite interesting talking to pregnant women who come to clinic and they say, oh, I'm really breathless. I'm only 7 weeks pregnant. And actually that follows in terms of what's happening to their physiology. So their cardiac output increases by around 50%. Stroke volume, so the amount of blood that the heart pumps out with each pump, is 30% increased. Heart rate goes up by about 25%. Ejection fraction, which is how much blood the heart pumps out with each beat, measured by echo, goes up by 20%. And left ventricular mass, so the amount of heart muscle, goes up 50%. This is balanced by reduction in systemic vascular resistance of 20%, reduction in pulmonary vascular resistance of 35%, blood pressure reduction, which is why they all go dizzy and faint, increased clotability, which you all know a lot about, increased tissue fragility, so that everything goes soft and squishy, including the aorta, and reduced oncotic pressure. So the slightly low albumin means that their blood vessels become a bit more prone to being leaky during pregnancy. And these changes occur really rapidly and quite early on. And I think this slide often surprises people. So cardiac output is the main thing. And if you look, it goes by week 5, we're already up at 10%. above where they were before. By week 8, 25%. And we're hitting 50% increase in cardiac output by around about weeks 20 to 22. And this is in cardiac women where we sometimes run into difficulty. So this is what they're going to struggle to cope with. And everybody usually assumes that this graph goes up in a linear fashion, and that you're just seeing a gradual increase that goes up slowly as the pregnancy progresses, when actually you do reach this peak at around about 20 to 24 weeks before it flattens off, and then it does go up a little bit again at delivery. But obviously the obstetricians and fetal medicine and neonatal medicine people in the audience know that this is a very difficult time in pregnancy because of the issues about fetal viability. If we have a woman who we are very worried about hemodynamically, if we can get past 24 weeks, I'm usually pretty confident that hemodynamically, unless things change with her heart, that she will cope at least to get the patient to a good level of viability, so a good gestation. Whereas if people are struggling at this kind of area, so 20 weeks, we know it's really, really touch and go as to whether we're going to be able to get to a point of fetal viability. So it's really important that that graph is what we look at. The other thing that's really important is what happens over here. So after 38 weeks, after the baby's delivered, all of this shoots back down. So the changes that have occurred over 40 weeks gestation go back to normal. These all plummet. So things like the systemic vascular resistance, pulmonary vascular resistance go straight up, cardiac output drops. So people will have seen us put these women onto high dependency on delivery suite after the baby's born. And that's because when the baby's born, people tend to breathe a bit of a sigh of relief, think, oh, mum's done fine, this is great, baby's okay. Actually, it's post-delivery sometimes that things do start to go wrong. And that's just those very acute changes in cardiac physiology. And you know, we have to be really careful about that in the first 24, 48 hours after delivery. And so this is, we talked about the physiological changes, which are one of the reasons why patients die. And then also this issue about, you know, lapses in care or care which could have been better. So this is one of the things where I find Embrace reports slightly angst making to read. So they have these case vignettes. So an older woman had an uneventful pregnancy until 34 weeks when she developed chest pain on and off over 3 days and radiating into her back and left arm. She smoked, had a family history of ischemic heart disease and a history of hypertension, was given Entonox in the ambulance, which is known to treat ischemic pain. She was assessed in the emergency department. No one asked about risk factors for coronary disease. And despite an abnormal ECG, no further investigations. The obstetric team not contacted, discharged home from ED and found dead in bed the following day, and had extensive coronary artery disease and a thrombosed LAD were found at post-mortem. So loads of issues in here. Abnormal ECG, now people that aren't in the know, we you know, pregnancy, women who are pregnant have slightly odd ECGs. It just changes the axis and various other bits and pieces which can be normal, but you do need to know what's normally abnormal in a pregnant woman ECG and not brush off what is a clearly abnormal ECG. People seeing pregnant women assume that they're going to be healthy. So in this case, nobody asked her about risk factors for coronary disease, despite the fact that she had lots. And so there's a kind of assumption that's made that a pregnant woman equals a healthy woman, and that's not necessarily always the case. So we just need to be careful about that. So how do we avoid the tragedy of maternal cardiac death? So I think there's a few key things. So awareness of what's high risk and what is not, asking the right questions. So asking about symptoms, asking about past history, really important to ask about family history and be quite suspicious about family history. And then also to talk about risk factors. Patients need to see the right people at the right time. So we need to get information to make sure they do that and refer them appropriately. We also need to know what's normal and what is not. So a couple of things. We use a very simple test with our patients. So we call it the stairs test, but essentially all pregnant women should be able to manage a flight of stairs in one go without stopping due to breathlessness until they get to the top. We'll let them stop at the top, but if they can't manage a flight of stairs because they're too breathless to get up, then that should be a trigger, a bit of concern in your mind to think about why that is. Chest pain, it's almost always going to be reflux, but it's not always reflux, and we should always keep in the back of our mind that this is not always reflux, and could it be cardiac? The other thing that's not normal and is a really good clinical sign and gives you objective evidence that there's something going on is a persistent tachycardia. Now, we know that heart rate does go up around about 25%. So if you've got someone that's sat with a heart rate of 95, 100 with no other problems, then that's probably fine. If their heart rate is 130 persistently in sinus tachycardia, there is something. You need to find out what the cause of that tachycardia is, and it's a really good clinical sign. So if you go to think about the graph of the cardiac physiology, if the patient's trying to increase their cardiac output and they can't pump any more blood out, they will increase their heart rate to meet that need for an increased cardiac output. And one of the things that's been picked up on numerous reports is the issue about making a diagnosis. So when somebody comes in with chest pain, common things are common. So people look for evidence of a PE, and then you occasionally see patients that are discharged after diagnosis of a PE is excluded. So there's chest pain, PE excluded, discharged, but the diagnosis of what's caused the chest pain is not made. So it's make a diagnosis, don't just exclude things. And then communication, of course, in all directions is extremely important. And the good old-fashioned telephone remains the best real form of communication for patients that you're particularly concerned about. It's helpful to be aware of what the cardiac causes of maternal death are, so that you can kind of target what you think about. So 31% are sudden adult death syndrome. And if you think about sudden adult death, these are patients that are found dead in bed, sudden cardiac arrest. Some people will say, oh, well, we couldn't have done anything about that. And that's true to a certain extent. But if you look through the histories of these women, in some patients, that's absolutely true, that there was no preceding factors, no concerns raised, no anything. In other patients, there'll be clues. So episodes of syncope particularly on exertion, and a family history. And that, family history, and sometimes it's quite vague, but, my sister or my cousin or my dad or uncle died suddenly, dropped down dead at the age of 32. Nobody knows what the cause was. Now that should ring bells really into, is there something going on in this family? And actually, if that patient is referred back through to the genetics team, what they can do is pull post-mortem reports, coroner's inquest reports, even from ages ago, to try to find out what the cause of death in that patient was. So, for example, we had a patient a few years ago now who came to see us in clinic just because of, mostly because of ectopic beats, really, and she had a slightly large aorta on echo. And when we went back into the history, her dad had died when she was about 11 on Boxing Day, gone to the pub and never came back. And she had no idea why he died, and neither did her mum. But we went back and got the post-mortem report, and he died of aortic dissection. In fact, this family have got Loeys-Dietz syndrome, which is a really nasty conductive tissue disorder, which does have a very high risk of maternal complications during pregnancy. So it's important that we pick that up. 22% of deaths are ischemia. These are mostly older women, smokers, obese, type 2 diabetes, South Asian genetic origin with an increased risk of ischemic heart disease. Myocardial disease, so patients with previous heart failure, aortic dissection, some valve disease, and this will include patients from overseas with rheumatic disease, And a small number of pulmonary hypertension and a small number with issues associated with systemic hypertension. And actually only 7% of deaths, congenital heart disease, and these overlap with myocardial disease, aortic dissection. And I'll briefly mention that in a moment as well. So ischemia, 34 deaths, so 22% of the total. Again, really important that we look at these risk factors: older age, smoking, obesity, diabetes, hypertension, hypercholesterolemia, and family history of premature coronary artery disease. Myocardial disease, again, 18% of the total number of deaths. Dilated cardiomyopathy, myocarditis, peripartum cardiomyopathy, which you'll all have heard of. It probably is a real thing associated with pregnancy, but in quite a lot of women, it's just a pre-existing dilated cardiomyopathy, which is then exposed by the pregnancy itself. And they all cause an inability to increase cardiac output, an increased risk of arrhythmia and sudden cardiac death. Aortic dissection accounted for 14% of deaths. Only 2 were known to have a high risk of aortic disease pre-pregnancy, but 5 of these 21 patients had an antenatal family history of aortic disease or sudden death, which was not investigated. And this EMBRACE report found that almost 60% of these patients may have had a different outcome with improvements to care. So that's something that we all need to concentrate on. Pulmonary hypertension, in this report, 6 women died from pulmonary arterial hypertension. Only 1 was known to have pulmonary hypertension before pregnancy. And these patients need diagnosing promptly and treating by specialists early to improve their chances of surviving their pregnancy. Congenital heart disease, most of them are known to services and have the opportunity for appropriate counselling and care. And despite the fact that we're seeing a very significant increase in the number of complex women coming through who are pregnant, the death rate's not going up, and that's probably related to quite careful care and pre-pregnancy counselling and an awareness that they've got disease prior to pregnancy so they can be properly looked after. So asking the right questions, and this is really kind of booking visits I'm talking about. So this is midwifery booking visits. So past history, does the patient have a past cardiac history? Sometimes it will be spectacularly vague. Don't rely on the patient saying it's fixed. So great example of this was a lady who was from overseas, came to a booking visit, told the midwife that she knew she had a murmur. English wasn't her first language, which again is an issue. Told the midwife that she was known to have a murmur and she'd been told it was a hole in her heart when she was overseas. And then, so that was taken as read. An echo was booked, which is great. That's what needed to be done. But in fact, what she had was severe aortic stenosis. So don't rely on what the patient says necessarily. Try and get some clarifying information. Past history of syncope on exercise or other cardiac symptoms. Really important, as we've mentioned, family history, any aortic dissection, sudden cardiac death or unexpected death in a young family member. Talk about risk factors. Talk about symptoms, chest pain, undue breathlessness. These are really important. And then we just move on to guidelines. Now, I'm not a great fan of guidelines. I think what happens to guidelines is that they get written, they get spread around, they get put on a website somewhere, and then often they don't get looked at very much. So we try and do this every so often to just try and clarify these guidelines. So this is our Yorkshire and Humber Congenital Heart Disease Network pregnancy care guideline. And we'll just run through some of this. So it's to summarise that pregnant women with congenital heart disease are categorised into 4 levels of risk in relation to the complexity of their condition. And we're very happy to triage referrals into low, moderate, high, and very high risk so that we can direct patients' care appropriately. So these are low risk patients, and Ellie will speak to you quite a lot more about this. So mild valve disease, mild pulmonary stenosis, small VSDs, repaired ASDs, VSDs, isolated PDAs, bicuspid aortic valve, which works well with no aortopathy. Usually care will be local and as I say, Ellie will talk about this. This guideline can be picked up on our network website or also on Leeds Health Pathways, although Leeds Health Pathways at the moment is being revamped and that link is not live, but we will make it live again. Moderate risk patients, moderate aortic or mitral regurgitation, mild mitral stenosis, moderate aortic stenosis, unrepaired ASDs, repaired Fallot's tetralogy, good well-functioning arterial switch. We will usually see these patients in the regional centre 1 to 2 times during their pregnancy, but most of their care is likely to be able to be local. But we would usually, join with people to come up with a plan to make sure that everybody's happy. High-risk patients, severe aortic or mitral regurgitation, moderate severe aortic stenosis or mitral stenosis, coarctation, congenitally corrected transposition, patients with a Fontan, cyanotic heart disease, people with aortopathy. So these patients usually seen a number of times through their pregnancy at the LGI or at their other cardiac centres, so in Sheffield or in Hull, and we would normally deliver these patients. So ones with complex congenital heart disease will be delivered at the LGI. Ones that have got maybe valvular disease that's non-congenital potentially get delivered in Hull or in Sheffield as well. And these are the group that are really high risk. So these are the ones we want you to be ringing us about. So bicuspid aortic valve with aortopathy and maximum aortic root greater than 45 millimeters, Marfan syndrome or other connective tissue disorder with a dilated root, pulmonary hypertension, severe systemic ventricular impairment, and patients with mechanical or metal heart valves. And these patients are the ones that really high risk. We see them pre-conception or as soon, we certainly would aim that these patients would all have preconceptual counselling, but in some of these patients, there follows a difficult discussion about whether the pregnancy is going to continue in the first instance. So this is what the regional referral pathway looks like on Leeds Health Pathways, and essentially, although there was in the dim and distant past, there was a form, but we don't use a form anymore. We just ask you to email through to our group email address, which is this, or obviously to your local team, and those referrals will be reviewed on a regular basis. So, as I say, this is where we are in our region, Leeds, Sheffield and Hull as the 3 surgical centres. Leeds is the only centre that offers same site delivery, and that can be important for certain patients. Sheffield have a very good workaround. Obviously, they deliver their pulmonary hypertension patients not same site as cardiology, and they do that very safely and very well. But in some patients, this does have advantages, and of course, the local units are managing many patients with mild congenital lesions or acquired cardiac lesions with no increased risk at all. So what we see is a team effort across the region, which includes cardiologists, obstetricians, midwives, specialist nurses, anaesthetists, and patients and their families as well. I've put cardiac surgeons in brackets because we really hope not to need to involve cardiac surgeons in women who are pregnant with cardiac disease, but we do have to do that at times. And I have great respect for our surgeons who step up to the plate to manage some catastrophic issues that do occur. Also, the haematologists are really important in the management of women with cardiac disease. If you don't know who the best person to refer is to, then we will. So just get in touch. What we're aiming for is healthy mums and healthy babies. Can we do better? Well, probably we can with increased education, improved services, learning lessons across the region, and increasing collaboration, which is all the things that hopefully sessions like today are all about. Just some further learning opportunities for those of you who are interested. UK Maternal Cardiology Society was set up about 2 years ago, and it crosses across midwifery, nursing, obstetrics, cardiac services and anesthesiology, and this is the annual meeting is in a couple of weeks' time. There is a charge for this, which is essentially the same charge as joining the society itself. So there's an encouragement to join the society, and then you get the benefits of that. And I think this is quite a good session. So hot topics, what do we do with palpitations, syncope and near syncope, new presentation of a murmur, new onset breathlessness, family history of heart disease, and other common questions. So that will be a really good session. These guidelines, so ESC guidelines from 2018, I know other people will mention these, but they're actually really very, very well written, quite concise and really helpful. Those of you who are Twitter fans, if you follow cardio obstetrics, you'll find loads and loads of stuff that comes up on Twitter. So with that, I'm going to finish and stop sharing this screen.